Welcome to the Neurocritical Care Society POCUS Bytes. On behalf of the ultrasound section of NCS, welcome to a bite-sized tutorial on cardiac POCUS, where we'll focus on the parasternal long axis view. My name is Diana Alsbrook, a current neurocritical care fellow and ultrasound enthusiast, and I'm excited to learn with you today. Let's start off with the most important thing, the why. Your goals of the parasternal long view can be many, but here are the main three. In your critically ill patient in the ED or the ICU, you can use this view to quickly assess the patient's approximate ejection fraction, assess for right heart strain for concern for things like pulmonary embolism, and to look for pericardial effusion. You can use this in so many different patient presentations, including hypotension, dyspnea, chest pain, trauma, cardiac arrest, many others. Like a lot of things we do as providers in the ICU, patient positioning and setup of the procedure is key to success. For the parasternal long axis view, the patient should be supine, or sometimes more ideally in a left lateral decube position. The probe you will use is seen at the top of the screen and is called the phased array probe, affectionately known as the cardiac probe to many intensivists. Ideally, you would set the machine to the cardiac preset, and you'll know you're set when you see the indicator on the right side of the ultrasound screen as opposed to the familiar left side in most other presets. Take the time to get familiar with your institution's ultrasound machine for you to be as agile as possible in getting the perfect views. For this view, our optimal depth is 12 to 16 centimeters to see all of the pertinent structures. Tell the patient what you're doing, get your ultrasound gel, and you're ready to place the probe on the patient. For the parasternal long view, we will place the probe classically in the third or fourth intercostal space to the left of the sternum, which will be your right. However, keep in mind that everybody's anatomy is slightly different, and getting a good view may require adaptation on your part. For this view, you will have the indicator on the probe pointed towards the patient's right shoulder. After all of your preparation, and with a little practice and repetition, you're rewarded with this great parasternal long axis view. And now we can start looking at normal anatomy and some abnormal pathology. Let's talk about some of the structures you're trying to see. This is an ideal parasternal long axis view. So, most anterior towards the top of your probe, you will see your right ventricle or right ventricular outflow tract. As our probe continues to cut through this section of the heart, on the left of your ultrasound screen, you will see the left ventricle, which you can identify with its thicker walls, the outer free wall, more posterior, and the septum that separates the right and left ventricles. Ideally, the apex is not seen. To the right of the left ventricle, you will see your aortic valve and the left ventricular outflow tract feeding into the ascending aorta. The left atrium is more posterior, and to the left of that, you can see both the anterior and posterior leaflets of the mitral valve. At the bottom of the screen, making your ideal parasternal long view, you will see the descending aorta. So we'll get to pathology, but before you learn abnormal, you always have to learn normal. Here's a video of what appears from a qualitative standpoint to be a normal left ventricular ejection fraction. You can look at a few things to help you determine EF in this view. You want to see both the septum and the left ventricular free wall. You want to see them contracting. You can see here they are both moving towards each other and contracting, but not meeting all the way in the middle, which we'll discuss later. You also want to look at the anterior mitral leaflet in this assessment. The opening and closure of this are associated with left ventricular ejection fraction. In a normal study, this leaflet should not come all the way across and slap the septum, but it should come close to the septum in diastole. There are advanced ultrasound techniques such as E-point septal separation and fractional shortening to look at quantitative ejection fraction that we will discuss in later videos. A lot of knowing what normal looks like is looking at it over and over and over again. Repetition is your best friend in any form of ultrasound learning. That is it for our brief overview of the parasternal long axis view and cardiac POCUS. We will have a later video to go over some examples of pathology in this view that will follow up on this video. Thanks for joining us for the Neurocritical Care Society POCUS Bytes. Please follow us for more videos like this and visit neurocriticalcare.org to view previous and upcoming POCUS webinars. See you next time.